Hello, my name is Joanna Cohen, and I am the Director of Emergency Ultrasound at Children's National Medical Center. And today we are going to be talking about cardiac ultrasound. The objectives of this talk are going to be to discuss the indications for emergency department ultrasound, to review the image orientation and views of point-of-care ultrasound of the heart, learn how to identify pericardial fluid and differentiate that from pleural fluid. And we're going to talk a little bit about using echo in the undifferentiated hypotensive patient. And as we go through, we'll talk about techniques to improve image quality and overcome some of the barriers. So what are the indications for point-of-care echo? Trauma, such as penetrating chest trauma or blunt trauma as part of the FAST exam. We use echo in hypotensive patients when we don't know the cause, such as part of a hypotensive patient protocol. We can use echo for rapidly identifying possible etiologies of hypotension as an extension of the physical exam. And sometimes we use echo in ACLS after cardiac arrest or during arrhythmias, or in dyspneic patients. There are other times that we use point-of-care echo that are not part of the ASEP indications, but can be helpful in patients with chest pain, ischemia, valvular disease, or aortic pathology. So what can we reliably see on point-of-care echo? Well, the first question we always want to ask ourselves is the heart contracting? And if the heart is contracting, is it contracting normally? And then we want to know if there's an effusion. And the third question that we often ask ourselves is the right side of the heart or the right ventricle enlarged? We can also identify regional wall motion abnormalities. So when we start to think about how to actually image the heart, we start thinking about cardiac image orientation, which can be difficult because of the variable position or lie of the heart in the thoracic cavity. The standardized views aren't really designed to make sense, and it's different than the abdomen, where we talk about imaging with the probe in the cephalad or right-sided position with the probe marker cephalad or to the right. And to make things even more complicated, a lot of the echo machines or the cardiac machines, you'll see that the orientation marker's on the right side of the screen. But in emergency medicine, we always keep the probe marker to the left side of the screen because we scan both above and below the diaphragm. For this reason, you might notice that your pictures look a little bit different than the cardiologist's pictures. So when you think about the heart lying in the chest, you can think of it like a tube. And when we talk about the long axis of that tube, what we're talking about is cutting that tube as if it were an open-topped water slide. And the short axis would be cutting it so that it looked like a donut. And those are the two main axes of the heart that we're going to talk about. Unfortunately, it can be very difficult to image the heart because it has poor acoustic windows. For one thing, the heart is encased in the chest wall, which is covered in the rib cage. And there's also interposed lung between the heart and the chest wall. And that lung is filled with air. And what we know about air is that it's really the enemy of ultrasound and can create a lot of artifact. But patient positioning may be really helpful. So one thing we'll have the patient do is roll onto the left lateral decubitus side or lean the patient forward to bring the heart closer to the chest wall. In general, you want to be able to image the heart with at least a quarter of the screen visible behind the heart to make sure you're not missing anything. There are 4 standard views that we use to look at the heart: the subxiphoid view, the parasternal long axis view, the parasternal short axis view, and the apical 4-chamber view. We're going to start with the subxiphoid view because you're probably already a little bit familiar with it from the FAST exam. So the subxiphoid view uses the liver as an acoustic window. The transducer is placed just below the xiphoid process with the orientation marker towards the right shoulder and the beam pointed towards the head. This is the view in which you use an overhand grip to get a very flat angle against the abdominal wall. The subxiphoid view is a good all-purpose view. away from the chest, which means it's helpful in patients who are lying supine, patients who are in cardiac arrest where CPR is being performed, or as part of the FAST exam. It can also be helpful in patients with COPD where the lungs are very hyperinflated, making the parasternal and apical windows difficult. However, the subxiphoid view can be limited in patients who are very obese or in patients with severe abdominal pain. This is the probe positioning for the subxiphoid view. You could see you're right below the xiphoid, and this flat area here is the face of the probe. So you're aiming the beam towards the heart, but coming from below the liver. This is a normal subxiphoid view, and you can see that the liver will always be at the top of the screen, followed by the diaphragm and the right ventricle in the field just distal to the liver. And if you can find that right ventricle, you can identify the septum and the left ventricle and the right atrium and the left atrium. So here's another subxiphoid view, just like what we talked about with the liver in the near field, followed by the right ventricle and the septum and the left ventricle and the left ventricular lateral wall. And here's what it looks like in motion. To improve your subxiphoid view, you can slide your probe further to the patient's right to use more of the liver as an acoustic window. You can stay high in the epigastrium and have the patient take deep breaths, or you can keep the transducer at 15 degrees to the abdominal wall. We're going to turn our attention now to the parasternal imaging planes. This is the parasternal long axis plane from below the left nipple to the right shoulder, and the short axis from the xiphoid to the left shoulder. So to get a parasternal long axis view, you want to place the probe in the third or fourth intercostal space near the sternum. That tends to be around the nipple line. You're going to have the beam angled towards the right shoulder with the orientation marker towards the left hip. You want to rotate the beam so it's parallel to the long axis of the heart. And you need to keep in mind that the heart axis can vary. So in patients with right ventricular hypertrophy, you might see a right axis deviation, whereas patients with left axis deviation may have a left-sided heart disease or a canal defect, or sometimes it's just a normal variant, particularly in pediatric patients. The parasternal long axis view is good for looking for left pleural and pericardial effusions. The parasternal view is also the only location to see the posterior wall of the LV, and you get good views of the aortic outflow tract, the mitral valve, the left ventricle, the left atrium, the right ventricle, and can measure wall thickness and compare it. You can adjust the depth so that the circle of the descending aorta is approximately 3/4 of the way down the screen. Seeing the descending aorta is vital to distinguishing pleural from pericardial effusions, and we'll talk more about that in a little while. This is what the normal parasternal long axis view looks like. You can see in the near field of the screen that we have the right ventricular outflow tract, and distal to that, the left ventricular outflow tract, and then the inferior wall of the left ventricle. Here's a normal parasternal long axis view. You can see the descending aorta is located about 3/4 of the way down the screen. Here's what it looks like in motion. For the parasternal short axis view, you really just want to rotate the probe 90 degrees clockwise from the parasternal long axis. So again, the probe is in the second to fourth intercostal space near the sternum, with the beam angled towards the right shoulder and the orientation marker this time towards the right hip. What you end up with is a donut view of the left ventricle, where you can identify the septum, the anterior, lateral, posterior, and inferior walls. You want to fan through the left ventricle from the apex to the base, identifying the papillary muscles, the chordae tendineae, the fish mouth view of the mitral valve, the left atrium, and the Mercedes-Benz view of the aortic valve. So here's a normal parasternal short axis view, and you can see the papillary muscles in the diagram here with the anterior wall, the lateral wall, the posterior wall, and the septum all visible. In the real echo image next to it, you can identify the chordae tendineae and the beginnings of the mitral valve in that fish mouth view. So the left ventricle looks like a donut, nice, muscular, and round, and the right ventricle is floppier and surrounding the left ventricle. Here is that same parasternal short axis view, a little more cephalad, where you can see the aortic valve looking like a Mercedes-Benz sign right in the middle, and the right atrium, the tricuspid valve, the right ventricular outflow tract, and the pulmonary artery surrounding it. This is the view that our pediatric colleagues identify a patent ductus arteriosus in, because you can see the relationship between the pulmonary artery and the aortic valve. And if you have a jet from the aorta to the pulmonary artery in this view, you likely have a PDA, and ultimately that can lead to some pulmonary hypertension if left untreated. Here's what it looks like real time as you fan through from caudal to cephalad, and we can watch this for a moment and see the papillary muscles, the fish mouth mitral valve, and as we come up we start to see the aortic valve. Here's the same view but with a depressed ejection fraction, and you can just see that the squeeze is pretty poor here, and this is at the level of the fish mouth mitral valve. The next view that we're going to talk about is the apical 4-chamber view. For this view, which is often considered the most difficult view, you place the probe at the point of maximum impulse with the orientation marker towards the right hip, aimed towards the right shoulder. It's really a slide over from the parasternal short axis, and it gives you a coronal view of the heart. It can be difficult to obtain, and this is the view where you really want to consider rolling your patient over to the left lateral decubitus side if possible. If the heart looks artificially short or round, you can fan a little more anteriorly. It'll give you a good view of the right and left ventricular function and the intraventricular septum. You also get a nice view of the mitral valve and the tricuspid view, which you could use to put Doppler on it and look at the flow across the valves. So here's what the normal apical 4-chamber view looks like. And you can see it's called the 4-chamber view because it's really the only one in which you get a good view of all 4 chambers. And here's what it looks like in motion. We're going to move forward now and talk about effusions. To differentiate pericardial from pleural effusions, you need to see the descending aorta in the parasternal long axis view. A pericardial effusion will track anterior to the descending aorta, whereas a pleural effusion will track posterior to the descending aorta. Here's a view of a parasternal long axis with a pericardial effusion, and you can compare this to the parasternal long axis with a pleural effusion. You can see here that the effusion runs behind the descending aorta. Here's a view with both the pericardial and a pleural effusion, and you can see the pericardium and the effusion tracking anterior and posterior to the aorta. We're going to run through a few images right now, and I'm going to give you a minute to identify what you think, where you think the effusion is. So this is a parasternal long axis view with what I would describe as a small pericardial effusion. You can see that effusion tracking anterior to the descending aorta. A very similar image with a small pericardial effusion, only this time that effusion is also anterior to the heart, so posterior and anterior to the heart, so a little bit bigger than the last effusion we saw. In this image, we have an even larger pericardial effusion. Here you'll note that this is a very big pericardial effusion, and you can see the heart kind of swinging back and forth within it. This is the phenomena that leads to electrical alternans. This is where the QRS axis alternates between beats, and it's a sign of a severe effusion or even tamponade. Essentially what you're looking at is the heart wobbling in the fluid-filled pericardial sac. Here's another pericardial effusion, and you'll notice that this one looks a little bit different. The fluid looks a little hypodense, right, as opposed to the pure black fluid we've been looking at before. But you'll notice that it still tracks in front of the descending aorta, indicating that it is a pericardial effusion. This is a parasternal short axis view with a small posterior pericardial effusion. Here's another parasternal short axis view with a slightly larger pericardial effusion. You can see how it tracks anterior to the pericardium in this view. And finally here you see a parasternal short axis view again with a much larger effusion and the heart making that swinging motion within the pericardium. So sometimes people get a little thrown off when they see this view after seeing a number of parasternal long axis views. So this is a subxiphoid view, and the way you can tell for sure is you can look at the near field and see the liver in the screen. And this is what an effusion looks like in the pericardial view, and you can see that it's both anterior and posterior to the heart. This is an apical 4-chamber view with a pericardial effusion. Here's another apical 4-chamber view, only this one has a large effusion and we could see the heart swinging in it, again, indicated that there's likely electrical alternans on this person's EKG. Sometimes there are false positives and false negatives when we're looking for effusions. Some of the false negatives include loculated effusions, isodense hematomas or hemopericardiums, or fibrinous exudates. Some false positives can be anterior pericardial fat pads, which are never found posteriorly, but they have scattered reflections, and we'll look at one of those. Prominent coronary sinus can trick people out, as well as the descending aorta and a mediastinal mass. This is an old EKG of a patient that Dr. Boniface saw, I believe, and this was a patient that was actually shot in the chest, sent home, and returned later and found to have this clotted hemopericardium. This is a patient with a pericardial fat pad. So you can see where that anterior black stripe could be confused with a pericardial effusion, but if you look closely, it has some bright reflections in it, and it's only located anteriorly. This is indicative of a pericardial fat pad. So how do we describe pericardial effusions? Well, we can indicate whether they're located just posteriorly or whether they're circumferential. We can talk about how thick they are. We can measure them at their greatest width and say whether or not they're more or less than 1 centimeter. Or we can look at the cardiac cycle and mention whether they're present throughout the entire cardiac cycle or whether there's effacement of the effusion during diastole. I want to talk a little bit about pericardial tamponade and point out kind of the most obvious thing about it, which is that the absence of an effusion rules out tamponade. Tamponade is mid to late diastolic collapse of the right ventricular and or the atrial wall. Systolic collapse indicates very extreme tamponade. Here's what tamponade looks like on echo. This is a parasternal long axis view, and you can see that right ventricular wall and a little bit of the left ventricular wall collapsing during diastole. Here is another case where we can see a pericardial tamponade in 3 different views: a parasternal short axis, a parasternal long axis, and a subxiphoid view. In all 3 of these, you can see the right ventricle collapse as well as the left ventricle. Here's another case, similar problem. We have the parasternal long axis, the parasternal short axis, and the apical 4 view, all showing extreme tamponade, and you can really get a sense here of why you would see electrical alternans on your EKG as we see that heart swinging back and forth. What other clinical scenarios do we use echo for in the ER? So we've already talked about cardiac tamponade, but we often do echoes in patients who are hypovolemic or hemorrhaging or have sepsis, and we'll see a small hyperdynamic LV. You can see near complete ventricular emptying and flattened IVC with exaggerated respiratory variation. We also can do echoes in patients who have cardiogenic shock, in which case we'd see a large dilated hypocontractile left ventricle, a dilated IVC with decreased respiratory variation, or in patients with right ventricular overload, as if from a massive PE or an RV infarction, we can see a dilated RV and RV hypokinesis with normal LV function. Over time, a number of ultrasound protocols around hypotensive shock began to be developed. I put this slide up here not so that you remember each protocol and what went into them, but just to show you the evolution of protocols. The most commonly used protocol now is the RUSH protocol, or the Rapid Ultrasound in Shock in the Evaluation of the Critically Ill Patient. This protocol incorporates echo, IVC, fast, lung, looking for abdominal aortic aneurysms, and looking for DVTs into a protocol for undifferentiated shock. Before we move forward, I want to just show you a little bit about the IVC. So the IVC size has been correlated with the central venous pressure, or the right atrial pressure. And what we know is that the smaller the IVC is and the more likely to collapse, the lower the RA pressure is. This is not entirely applicable to pediatrics, and so I want to put that out there for our PEM colleagues today. So the RUSH protocol involves looking at these 5 exams. We're looking at the cardiac exam for the ejection fraction, looking for RV dilation, looking for pericardial effusion, and specifically looking for tamponade. We're also looking at the IVC for the diameter and the collapsibility to assess for RV pressure. The FAST exam can help you identify peritoneal and pleural fluid, and the abdominal aortic exam can help you identify an aneurysm. And then we also look at the thorax and the lungs to identify a potential pneumothorax. Point of care echo can also help us in ACLS. When we have a patient with PEA, it can help us identify if the heart is contracting or not. It can also help us look for reversible causes. For example, is there a large effusion? Is the heart hypocontractile? Might ionotropes be helpful? Does there appear to be volume depletion, like a small hypercontractile LV and a collapsed IVC? Or is there RV overload with a dilated IVC and an enlarged right ventricle? The other thing we can see are regional wall motion abnormalities, and sometimes we get a surprise. For example, this patient had an echo, and what we see here is a large clot in the right atrium. This is just a little while later with that clot being moved to the right ventricle. Occasionally, we can also see endocarditis. So here you can see a sort of embolus on the tricuspid valve swinging back and forth. This is a patient who had an echo with asystole, and what you can see here is that the heart is not contracting, but we still see some fluid moving through the heart. So what is that? So that's actually the IV fluids being pushed through the chamber. And I put this up here just so that we don't get confused with this and some sort of function. So we're going to close out now with a few take-home pearls. So these are the things I'd really like you to remember from this lecture. The first is to know the 4 cardiac views: the subxiphoid, the parasternal long, the parasternal short, and the apical 4. And we will learn more about how to acquire these on the hands-on sessions, but try to remember that if you're having difficulty with the apical 4, you can try the left lateral decubitus position. And make sure to use the descending aorta to help differentiate pleural and pericardial effusions, and consider POCUS for patients with undifferentiated hypotension or arrest. Thank you.